All right, so the patient I have my case study over is one that actually has been there since, if I remember right, they told me October of 2019. So she's a female, 36 years. She is 170 centimeters, or it's about 5'6", weighing at 78 kilograms. She's a folk hold, and the chief complaint, or the reason they admitted her is because it was a post cardiac arrest. So, kind of going into that, the patient history was obtained from her daughter. From according to her daughter, they were about to watch a movie together. The daughter stated that the patient was feeling weak all day. Was just overall did not feel well. Other than that, there was no other prior sign or symptom of what happened, at least that we were told by the daughter. Um, so what they believe happened, or what they determined that happened, was patient went into cardiac arrest. She did stop breathing. The deputy that did arrive on the site started perform CPR, and uh, she was then shocked twice and brought back. They intubated her on the site, and then the facility she was previously at, they had to transfer her to Regional West, so my clinical site, to get a higher level of care. Patient is awake. When she first got there, she was unconscious, or I think she was in a coma for a while, and then she woke up and she's been awake, but not as alert as you would think. She does have some eye movements. However, it's not. She's not able to say yes, no, talk at all, give any responses like that. Um, there wasn't too much prior medical history until this all occurred. Um, a lot of this had to be obtained. Uh, well, let's see. It was obtained from the previous uh, facility she was at. Other than that, we couldn't gain much from the patient herself. So, so in terms of any medical surgical history, there is a diagnostic excision of stomach via an artificial opening. We have blood transfusion, respiratory ventilation. There was no notable smoking history, at least that we could obtain, but there is a previous history of tobacco use, so we don't know how much exactly she was smoking. In terms of occupation, any occupational hazards, there wasn't any listed. The occupation wasn't listed at all. Patient's overall appearance, I'm not too sure on the date of admittance to the facility. However, I was able to help care for this patient quite a bit. Um, there was never any signs of distress. Vital signs were pretty normal. The only things that changed quite a bit were her breath sounds, and um, she was intubated, or she did have a trach. So it'll be kind of talked about a little later, but they put her on Mucomist just to help keep that a patent airway with all that. Regular trach cleanings were done, suctioning. There was, depending on the day, there could be a lot of thick mucus, or it would be relatively normal, pretty clear. It just depend on the day. But yeah, as I said, her vital signs were normal. There's nothing very notable about those. The breath sounds though, I think it's up next. Talking about the chest X-ray that was performed. There was some development of atelectasis. So, the right and lower lobes were diminished, and then just a few days later, they were then coarse. Going into the lab values, um, for the most part, most of them were in a relatively normal state. The only ones that were really notable were the creatinine and glucose levels. However, the glucose could be that the patient is in a fasting state, or that, let's see, a possible diabetic. However, she could have just eaten, came off that fasting state. There's a lot of variables there, so I don't believe it was too much of an increase. And then the glucose. The glucose is what could be. I apologize. Let's see. The glucose is the reason why I directed toward the point or the possibility of diabetes, or the fasting state, or the patient just ate, and that would also involve the let's see, yeah, no, and creatinine, is it's not overly low. It's, I believe, 1.1 below normal. And then this is about the CXR. So this is the actual CXR or CT scan. These are just kind of a good example of what could have been seen. So there was that atelectasis that I did mention. There was a hazy opacity in the mid-right lung that was beginning to develop, which could lead to some possible fluid buildup. Other than that, there was no big notable changes. The trach was in place. I believe there was a slight shift, and otherwise there was no pneumothorax, pleural effusion, nothing of that sort. Let's see. It is good to note that this patient did suffer from an anoxic brain injury, which means there was there was not enough oxygen being delivered to her brain, which did put her into this place. I'll kind of discuss that a little bit later. But since she is now bedridden, there isn't very much walking or any movement that she can do. She is more prone to developing these kinds of condition, or this kind of a condition. So some of the medications that they did have her put on are listed here. A lot of it is to treat GERD or high stomach acid. There is one here, folic acid, which will help treat certain types of anemia. And then again, there's that Mucomyst listed, and that is just going to help keep that mucus not as thick and easier to suction. That way it's just not sitting in there. Okay. So the patient did present with atelectasis. It did look like there was a possible pneumonia just due to a bacterial or anti medication to prevent some bacterial infection. But we'll go with the atelectasis. So the patient did present with diminished red cells at first, and now they are coarse, and presented with an uncompensated respiratory alkalosis. She is on a 5 liters per minute oxygen via a trach collar. Let's see, I kind of read off her ABG. So the pH was 7.5, PaCO2 is 34, which is, it's below the limit. It's not overly below, but it's still below. The PaO2 was 97.1, which is really normal. And then the bicarb was 25.7, and it's still in that range. It's getting high, but it's still in that range. So the CXR as well, I did mention earlier, there was a slight mediastinal shift, not rift, and then that density in the lower left lobes. Pneumonia was indicated, at least to me, a little bit, and then I kept looking into the patient, but there was no fever, no increased white blood count. There was nothing indicated on her CXR. So it was kind of became contraindicated. All right, and then just this overall summary. So this patient, like I said, was has been there for, see, October through, or we're recording this in April, almost 6-7 months. So that's a definite long-term patient who is finally stable. They don't know exactly in terms of long-term on anything discharge-wise. As I said, the patient is suffering from a anoxic brain injury, so there's not much really going on in terms of how she is able to respond or track things with her eyes. A lot of it, the patient has to rely on others to perform the cares. There, every now and again, the patient does breathe relatively well. There was a time where there was no oxygen being given to her, and the patient did well without it. However, it was humidified air, so without that, they just kind of took her off of that. But in terms of oxygenation or SpO2, it stayed into a normal level. So really, all they want to do is to keep a patent airway, keep in a stable condition as best as they can. Make sure there's no further complications, prevent any further complications. There's not much to do other than monitor and keep a close eye on her. Really, there was a lot of notes on this patient when I began making this care plan on them, but from start to now, or I did this one back in February, but due to all this COVID and not being able to go to clinicals, I'm pretty sure that the patient is still in a stable condition. I can't say that for a fact. I would like to say that she is, but even then, October to February, there was just significant improvement throughout each month. And a lot of these tests, so I'm going to go back through here real quick. So as the lab values were drawn in February, so it was actually the date of the care plan I made. And then there was things such as, let me see what I can find here. There was a test, the ABGs. So the ABG was the last one was drawn in December 22nd of 2019, which at that time it was decent, but in terms of now, it doesn't really say much. The patient could be in a whole different condition. There could be something else going on. So really, this one is one I tried to monitor as much as I can because it was really interesting. It's a very sad case, but it's something you wouldn't necessarily see every day. It's not your typical COPD patient, asthma, exacerbation, anything of that sort. So I chose this one just because I thought it'd be good to share. And yeah, that is about everything. If you have any questions, definitely feel free to ask. I'll try to answer it best I can. Yeah.